The next speaker after Janice will be Dr. Cecelia Choi, who is a hematologist and an oncologist here at Metro Health Medical Center and heads the adult sickle cell program. She is an assistant professor of medicine at Case Western Reserve University and a staff at the Case Center for Reducing Healthcare Disparities. She is a recipient of the James and Susan Carter Humanitarian Award. Dr. Choi is an advisor to the United States FIDA, a nonprofit organization helping refugees and people of the Congo. She has been a past speaker for the American Cancer Society, Young Survivor Symposium, and Young Adult Survivor Conference, and recently at the Sickle Cell Anemia Health and Resource Fair at City Hall.
Good afternoon. I'm Dr. Choi. I'm one of the blood doctors here at Metro. I want to thank you, all of you, for making time this afternoon to come and maybe listen, learn, share about sickle cell anemia. But before I start, I want those people who have sickle cell anemia, sickle cell disease, sickle cell gout, however you want to say it, just to stand up, and I want to recognize you for what you've been through. Can we just give them a hand? Thank you so much. Appreciate that. I think just coming from my own background, in Asians there aren't that many patients with sickle cell disease. And when I came to Metro, that's when I've been exposed to sickle cell patients and what they're going through. And I think Jilly did an amazing job this afternoon just trying to capture some of the issues that surround sickle cell anemia. So because I'm also a physician, I get to kind of see them from a different, I guess, venue. And so for the next 15 minutes, I'm just going to briefly outline what sickle cell is, sort of the medical model, go through some of the treatments, and kind of touch base on some of the issues that they go through. So, you know, I think sickle cell disease has been around for a very, very long time, but it's not until 1949 when we really discovered what it was. And this was an article written by Dr. Linus Pauling in 1949, where he described why people have sickle cell disease. So this is actually a very recent disease to the medical community. What's interesting is after he discovered what this was, look what he wrote about 15 years later after he discovered sickle cell disease. He thought that if you had sickle cell trait, that maybe you should have a tattoo on your forehead stating that you have sickle cell trait, so you don't fall in love with one another. Yeah. And you know what? Some of you are laughing, but if you have sickle cell disease, you know what that means to you. And for those of you who have sickle cell trait, a lot of people want to even ignore the fact that they have sickle cell trait. They don't even want to think about it because of this sort of very strange phenomenon. And so what happened between 1940-something to 1966, like Dr. Pauling said, okay, this is something that's really serious. We need to deal with this because if we don't, then you're going to have lots of problems. That did not happen, by the way, which I'm very happy about. Yes. That would not be good. So a lot of people ask me, if I don't have sickle cell disease and my partner doesn't have sickle cell disease, how do we have a kid who has sickle cell disease? And just a very brief overview, if you have a gene, one from your dad and one from your mom, and you could actually, when we say carrier or have a trait, that means in order for you actually to have the disease, you need the sickle cell trait from both of your parents for you to actually have the disease. So if you see in this little diagram, you could have a carrier father who has a trait. So he may not even know that he has a trait. You could have a mother who has a trait. She may not know that she has a disease because at one point maybe they were tested for sickle cell, but nobody told them growing up. It's not something that you say, oh, okay, now you're 18, I want to tell you you have sickle cell trait. It's not something that you bring up to your kids. And so nobody really knows, and they fall in love, they have kids, and then they have patients with sickle cell anemia. And the chances of you getting a sickle cell anemia is 25%. So for somebody who is a carrier, that's 1 in 4 chance that you're going to have your offspring, your child will have sickle cell disease. there's 1 in 4 chance that that child will be normal, and there's about 50% chance that that child will be a sickle cell trait. So who is at risk? You know, we always think it's people who is from Africa originally. But if you look at this map, it's not just from Africa. It's from Central America. It's from Saudi Arabia. It's from the Mediterranean. If you look at the map, you can also see that it also involves Italy and Spain. So it's not just an African American disease. And if you also look at the map, there's different types of sickle cell disease. Everybody thinks that sickle cell disease is one disease, and it really isn't. You have people with sickle cell SS or SC or S thalassemia. There's a wide variety of diseases that sort of is grouped together as sickle cell disease. In fact, in the United States, about 65% have SS, but as you can see, everybody else is SC or sickle cell. And for those of you who have sickle cell disease, you kind of know which one you have. And the reason why this kind of get carried on is because for patients who have sickle cell disease, if you live in an area where there's a lot of malaria problems, then you're protected against malaria infection. But if you live in Cleveland, that doesn't really happen. So you're having sickle cell disease really don't offer any protection against malaria. But if you have 1.5 million people who die of malaria a year, you know, this may be a good thing. And in fact, I was telling some of the people that if you go to some part of Africa and certain tribes, if you have telltale sign that you have sickle cell disease, you are a, quote, prime marriage material, because they think that you'll be able to provide malaria protection for your offspring. Here in the United States, that is not really the case. So in the United States, about 100 people are affected by sickle cell disease, and among African American births is 1 in every 400. So that's a high, high number. It's a high, high number of a disease that nobody's talking about. Even among Hispanic Americans, it's 1 in about 1,400. Depends on where you live, but I'm going to say 1 in 1,400. About 3 million Americans have sickle cell traits. That's a lot of sickle cell trait people walking around who don't know that they have sickle cell trait. And about 1 in 12 African Americans have sickle cell trait. In this state of Ohio, there's about, I'm going to say about 3,000 to 5,000. And why that is so is because you would think with a disease that's this prevalent that we would have some sort of a national organization that tracks people with sickle cell disease, but we don't. So we have absolutely no idea who the people who has sickle cell disease. You know, I also take care of cancer patients, and with cancer patients, we know exactly when they were diagnosed, what treatment they got, what treatment they didn't get, their race, their sexual orientation. We know everything about them. When it comes to sickle cell disease, we have absolutely no idea. So this is just a guess. It's just something that Ohio just kind of published, and they think it's between about 2,500 and 5,000. What we do know last year, about 94 babies were born in Ohio with hemoglobin SS. So this is not just all sickle cell disease, this is just SS. And about 3,000 babies had trait. So how many of those 3,000 babies, you know, when they hit, I don't know, 18, 19, will know that they have trait? Not very many. So the CDC, the National Institute of Health, kind of got together and said, okay, this is a big problem, we need to deal with this. So there are 7 pilot states, and Ohio is not included. But their goal is to find out who has sickle cell disease and develop a national surveillance system to find out their health status, their health practices. Do they smoke? Do they drink? Do they go to school? Do they graduate from school? Do they go to college? What kind of job they have? It's to monitor this. And first they're going to do it with these 7 states, and then it's going to broaden to include other states. So even though there isn't a lot of things going on right now for sickle cell disease, I think the next few years, they're gonna, the government, the federal government is really interested in sickle cell disease patients. So this is a prime time for you to get involved, for you to tell your legislators, to tell your government where you wanna go with your health care. A lot of people come up to me and say, okay, I think I have sickle cell disease, but I don't know what it is. And just very simply, everybody has red blood cells. It's when you have sickle cell disease, the red blood cells is just shaped differently. And instead of being nice and round, we're actually not nice and round. It looks kind of like an inner tube and it's flexible. It's more like a crescent moon or a sickle, and it's very stiff. It's very inflexible, and it has trouble moving through the body, and it clusters together and block blood flow. And of course, we have blood throughout our body. So if you have any problems with blocked blood flow, then you may have problems throughout your body. One thing that patients get is they get severely anemic, and it's because these sickle cells do not last in the body as long as they can, and your body just can't replace the red blood cells fast enough, so you become anemic. And when you get anemia, you could get tired, you could have heart problems, you could get dizzy, you could faint. As you know, if you have sickle cell disease, you have pain crisis, which is extremely painful. On top of that, you have chronic pain. You are at risk of infection. You are at risk of something called acute chest syndrome, which is devastating and has a very, very high mortality if you don't treat it and go to the emergency room right away. You're admitted to the intensive care unit. So these patients, I want to let you know, are super sick patients. And they're super sick, and the treatment that they get is very different depending on which hospital they go to. So it's not a consistent, well-balanced health care throughout the United States. One thing we know about health disparity is that if you have sickle cell disease, I hate to be a downer here, but you have less access to comprehensive care. I think one of the reasons is because a lot of diseases have people backing them up. They have walks and runs and all these other stuff. When was the last time you actually were involved in a sickle cell fundraising or awareness? Kincaid Group, they do an amazing job. They have a walk. They have all these other events that they put on, but it's not really out there in the media. Media, I just don't find it as interesting enough. But if you keep on hounding the media and say, this is what we're doing, please, come to our event, take a picture of us, let everybody know out there what sickle cell patients are going through, and then maybe we'll have improved access to comprehensive care. But at this time, we don't. Most of these patients require hospitalization, treatments, and about a quarter of the patients, that's a typo, that should be adults. Approximately about 25% of the adults with sickle cell disease go to the emergency room more than 6 times a year. And I'm going to talk about the financial aspect of sickle cell care later on, but I got a call from various insurance companies recently where somebody spent over $200,000 in health care last year just by themselves. And so you're thinking, well, how did that happen? And so it's sort of not a great communication between the healthcare providers and the patients themselves. How we treat sickle cell disease is through pain medicine. By the time you are adults, what usually happens with sickle cell patients is when you're a kid, everybody loves you and thinks you're really cute, and you become the poster child of sickle cell disease. As soon as you hit 17 or 18, they say, okay, you're gonna leave us, you're gonna go see your adult hematologist and your adult doctor, and then nobody wants to take care of you anymore. And there isn't any support for you, you feel very alone, and it's a scary place. And by this time, your pain crises are getting worse. For some reason, when sickle cell patient hits their young adulthood, they just get more pain crises. I don't know if it's the hormonal changes or life stressors, but they do, and they start requiring narcotics or opiates for their pain control. And so when they visit different hospitals, they are labeled as drug seeking. And then once you're labeled drug seeking, then it's very, very difficult to really let them know what kind of pain you're having. We use a lot of combination therapy where we have a long-acting pain medication and short-acting pain medication to help you with your pain. We also have narcotic contracts, and this is really to protect you and to protect other people. There's so many people who actually die of narcotic overdose, so it's very important that you don't share your narcotics, that you don't use other people's narcotics, that you and your physician and your healthcare provider have an honest dialogue in terms of what kind of pain relief you need. One thing that Ohio State has is that if you have any narcotic prescriptions and you fill them, as a physician and as healthcare providers, we could find out exactly where you got your narcotics, who gave it to you, and when you filled it, and how many pills you filled it. And so this is really to help the Narcotics Division of Ohio to prevent narcotic abuse. In terms of transfusion, a lot of patients do require transfusions. If you have sickle cell disease, especially SS or S theta, or S thalassemia, as a child, you may have had a lot of blood transfusions. So now that you're 18 or 19 or 20, you come in and now you have something called iron overload, and you have too much iron. And when you have too much iron, it puts you at greater risk of developing pain crisis. And so we try to avoid that. We also do something called exchange transfusion, where we take some of your blood out and put another blood into you. This becomes a problem if you have, or if you are a Jehovah's Witness, or you belong to another organization that don't believe in blood transfusions. That's when you need to really have a talk with your provider and say, I don't want blood transfusion. Is there something else that could provide me with relief? And there are other things that we can use. So please keep that dialogue open. One thing that I use with many of my patients is a medication called Hydrea. And the reason how this works is when you're a baby, you have something called hemoglobin F. F stands for fetal or fetus. And so when you have hemoglobin F, you don't sickle. It's when you have hemoglobin S that you sickle. So if we give you this medicine called Hydrea, it actually helps your blood make, or your body make more hemoglobin F instead of the S. So we know that if you take this medicine, Hydrea, it reduces painful crisis, it reduces you from getting acute chest syndrome, and you need fewer blood transfusions. But this is a chemotherapy pill, so we need to monitor you very closely. If you have hemoglobin SC disease, this does not work as well, and so we usually reserve it for people who have severe SS or sickle cell. There's always people who come up to me and say, is there a cure for sickle cell disease? And I say, yes, there's actually a cure. You may have not noticed, but there is a cure, and it's called bone marrow transplant. And the reason why this is not available for most people is that in order for you to get the stem cell transplantation, you need a sibling. And you need a sibling that matches your blood type. And as children, when you have a kid that has a lot of painful crisis, they may consider the stem cell transplantation. When you're an adult, it's very hard to find somebody who is a match for you, and you already have so many health problems. Going through the stem cell transplantation may be more dangerous to you than just having the disease. So it's very rare that we would actually transplant adults. It is available at OSU, Cleveland Clinic, and UH. They both sometimes do it depending on how old you are. If you're just, even though you're an adult, maybe if you're a young adult, they may consider you for a candidate for getting bone marrow stem cell transplant. On the horizon, this is the exciting stuff. At the National Institute of Health, what would happen is, and this is just only around the Washington area, is that if you are a mother and you give birth to a baby who has sickle cell anemia, what they'll do is they'll save the cord blood, and then when that child becomes older, they would transplant that cord blood for you. And so this is, one way of just being mindful of something that could potentially cure your baby of the sickle cell disease. Again, this is something that's very new. It's only done at NIH, but I could see more and more hospitals around the country maybe adopting this based on the result of this study. The second exciting thing on the horizon is the doctors at University of California, San Francisco is doing stem cell therapy. So what they do is they take your blood and then they sort of force your blood to make normal red blood cells. And this is really exciting. They did it on animal models and it looks promising. And so for my patients, when this go into clinical trial, I'll definitely give you information to see if you could be a candidate for this stem cell therapy. Recently, I found out about the study that's been done by Dr. Malik. It's gene therapy, where they collect a small sample of your bone marrow. That's the factory that makes the red blood cells. What they do is they take it out, and they take a virus that's not going to cause any harm, but it's a virus that will go into your body, and then it'll make hemoglobin F. And so that if you have more hemoglobin F, the theory is that your hemoglobin S will go down and you won't sickle as much. They're going to enroll in this trial pretty soon. I heard in the next few months or so. So I will give you more information about this. And the thing is, there are so many things that we can do to cure sickle cell disease, but we need money. The researchers need money. If the money isn't there, the research is not going to be there. Did you know that there are 3 times more babies born with sickle cell disease than cystic fibrosis? And I quoted this statistics before. So for every baby born with cystic fibrosis, they spend about $3,000. For every baby that's born with sickle cell disease, it's about $300. And with the economy and the way that the government as well as private and other nonprofit organizations is just really scaling down on how much money they have, I'm thinking that this money actually will go lower. But what the government don't realize is how much it takes to take care of one sickle cell patient. We have, this is an old statistics, but spending $470 million on sickle cell patients. For children, it's about $15,000 a year to take care of them. Nationally, this is just for adults with sickle cell disease. There were about 83,000 people who were hospitalized. Again, about $500 million to take care of sickle cell patients. So if we tell the government, hey, if there's a way that we could prevent sickle cell disease, if we could do research to cure sickle cell disease, if we find better ways to monitor and educate the public about sickle cell disease, maybe you don't have to pay so much money later on as they become older, because it's not just about the money. You ask the older patients with sickle cell disease and ask them about their quality of life. Are they able to do the things that they enjoy? Or are they constantly in pain? And they're just chasing their pain with pain meds. They're not able to do anything that they find enjoyable. And so they're between pain and being sleepy. Pain and being sleepy. There is a way we could prevent this from happening. Okay? At Metro, it is a safety net hospital. As you can see, most of our patients are medicated. So we really need to ask the people in the government, please, please, please pay some attention to this disease. So in terms about candid conversation, these are the do nots. Do not hospital hop, because we all talk to each other. The doctors talk to each other. It doesn't give you a better health care. Make sure you take your own medicine. Don't share it with others. Don't take other people's medicine. Have that honest dialogue with your doctors. These are the do stuff. Besides just talking with your healthcare providers, maintain health screening. I think when you have sickle cell disease, things like mammogram, colonoscopy really doesn't mean a whole lot to you. But it does, because more and more patients with sickle cell are getting older, and they are getting breast cancer. They are getting leukemias and lymphomas and other types of cancer. Make sure you're vaccinated. Think about what you're eating. Eat healthy, exercise. A lot of people with sickle cell disease have difficult time exercising because it kind of brings on a pain crisis. And so it's a dialogue that you have to have with your physicians. Please participate in support groups, because we all need one another. I don't want anybody who has sickle cell disease to feel like they're alone and they have to deal with all these problems.